Okay, we're going to start, so please take your seat. Be comfortable. Recording. Okay, I'm really happy to be able to speak to you again. This time I'm going to talk to you about an educational program we make, but I'm going to give a lot of practical information that you can take home as a physician in your office. And if you're a patient, you will also learn a lot. And due to the COVID crisis that we had, there was the question, what can we do? What has not been done? And actually a lot has not been done of what we can do. And we will see one of those things is concretely to do prevention in order not to contract COVID. And when you contract it, give the right treatments that really work. And I'm talking here about hormone therapies and nutritional therapies that have high potency. And we'll also talk about the other question is, what can physicians do to continue on getting educational information? And this is possible by webinars. So the answer is this webinar. And basically what I'm going to talk about about a series of free webinars and that are overview webinars and a series of this webinars that is for a more profound cursus for physicians. And I think when you attend the free webinars, even non-professionals will want to attend the course because it's made so practical. And this is really, and I must give a real thank to my wife actually, who was actually the promoter of doing such a webinars series session. So she's our new project manager, and she has done a lot of work. And I also want to thank my team who has enormously worked on this project. So take your seat, be comfortable, and I really am going to talk to you in this session. And we'll go here back to this. This will be a PowerPoint presentation. And basically, the information I will give is how physicians and their patients can become fully alive with hormone therapies. Because you see that the COVID crisis has given us a real shock and even a lot of scare. It causes, and this has made us to raise an important question for physicians and their patients. And is life just a matter of suffering and surviving? Because the COVID crisis has given us a lot of suffering. People were jobless or had not much income. And basically, there was also the scare of getting the infection, of dying, or the even greater scare for me, at least, was to transmit the COVID, the coronavirus that caused COVID to other people. So basically, are we there to suffer, or can we find some way how to live much better, enjoy more, and become more than ever alive? I think really that we are on earth for a spiritual reason. And the spiritual reason is to become better people. How can you become better if you always are suffering? And while you have the tools just next to you and just in front of your eyes that can make you enjoy life much better, overcome difficulties much better with better insight, but also with the better health, and really feel alive. We are here on earth for one purpose: to be fully alive and to irradiate our good character and our good energy to others. And so this raises also other questions. Is life worth living, or are going to make our life something really worthwhile? First, what is health? To really understand that. Is health basically how medicine often works now, just a state of being free from illness or injury? I don't think so. I think we need to go to another definition of health, in which the health should be a state of physical and mental and social well-being, in which disease and infirmity are absent. You really feel good. It not only are not being sick, but you really have a feel-good feeling in the life. Now, what is really being alive? The basic definition in the dictionary is that it's not being dead. But alive is much more than that. It's a state of being fully alert and active and animated. And this is really important. Physicians are more and more focused on wanting their patients to be feel alive. And basically, I must also say you that physicians want themselves to be much more alive. And so in order to be much more alive and healthy, what can severely impair our health and make us less alive, that we don't live so well? Well, hormone deficiencies. Hormone deficiencies are really major conditions that will make your life a suffering, or also something where you don't feel good. And they provide fatigue, give a lower mood, and they can facilitate chronic diseases. And hormone deficiency can make us really less healthy and less alive. So we're missing the purpose of our life if we are too severely affected by hormone deficiencies. And this happens also to our patients. And hormone deficiencies can also facilitate COVID-19 virus. I'm giving a model of 2 months, 2 hours a week, intensive, fascinating stuff about how much it is important to correct not only hormone, but also nutritional deficiency and dietary indicators in order to be strong against any infection, including COVID-19. And hormone deficiency can also cause what is called a post-COVID-19 burnout syndrome. Many people feel burnout after they have the COVID-19 virus. It's like life is not anymore what it was before. And that can be due to that the coronavirus has caused also damage to the endocrine glands and thus hormone deficiencies. And that is correctable. That's the good news. So actually many people have and acquire during their lifetime hormone deficiencies that impair their health. And there's a high frequency of hormone deficiency in the population for just the reason is that with aging anyway, the endocrine glands that secrete the hormones age and get damaged and accumulate damage and work less. But also our food and some nutritional deficiencies can aggravate hormone deficiencies, and pollution can even cause it often. And we're not always aware of what happens and what we can do to improve that. And seems that my screen is a little bit blocked here. So let me see. Yes, here we have the first is, so how to become fully healthy and alive will be the purpose of today. And basically the main answer when there are really severe problems is hormones. We need to correct the hormone deficiencies by hormone supplements. And there's a lot of different kinds and different mode of administration. But people who do not do that may be accused of causing negligence to themselves, and the doctors who don't participate in correcting hormone deficiencies that they see in their patients may be accused that they might not be doing the best of the medicine, because correcting hormone deficiencies is generally, if you have a science to do it, safe and efficient. So to help improve the skills in hormone therapy, the Hertoghe Medical School, which I supervise, has set up a training program for physicians called Evidence-Based Hormone Therapy. And it's a 2-year program with a 1-year specialization through live webinars and online training. And at the end of the topic, I will talk more in detail. We'll also have a question and answer session. So if you have questions and answers you really want to pause, you can pause them at the end, and I will look over the questions and try to answer as much as I can. So this evidence-based hormone therapy training program, I think, is really what physicians need to have now, because it's extremely practical, a lot of evidence, but it also explained in a more easy way than in general most of lectures done on hormone therapies. And There will be webinars. There will be always a free webinar every month or every 2 months, depending on the length of the model that follows. That is actually an overview of video that gives an idea of what's in the model. And I think if you attend that, you will really like to register for the in-depth training program that follows. There's also one video lecture at the last session of the month with a question and answer session. So basically, these two models will be with question and answer sessions. So every month, once or twice, you'll be able to ask your questions. And there will be also pre-recorded videos in the training program, 3 per month, so that you have about 4 videos in the training program, plus an overview video every month. And the training program is also with CME credits. We have applied for CME credits. This is also why we're starting a little later. We're starting the 27th of October. So we're sure that we have CME credits. There's no additional hormone and phos work than the training program, but you will have the possibility of doing an exam at the end of each year. And let's look at the first topic of today, which is immunology and hormone therapies. And in the first model, that is a sort of 2-month model, you have hormone therapies to prevent and treat viral infections, bacterial and parasite infections, inflammatory disorders. But that's the basic and most important topic. Although, as you will see, we have the overview seminar on this 2 or 3 weeks before, and that is exactly, I will tell you, the 6th of October, we'll have this overview seminar, and I really propose you to be there because it will be exciting. I'm giving a lot of information because I think there's much information that everybody should get anyway for free. And then we'll do the first model, the first model session, which will go on all the dietary, environmental, and lifestyle therapies. We'll talk about how efficient the mask is to put on to prevent COVID-19 infections, but also our airborne microbiome that, you know, we're full of bacteria in the air. And I spread in my office every 2 days some bacteria so that I have a good microbiome. We'll tell what the science is behind there. We'll talk about air dryness and humidity, how you can really, by modulating that, get optimal protection against COVID and other types of infections. And then we'll talk about what foods to eat to really improve your immune system, and eventually what foods to avoid, also to avoid having autoimmune diseases. And we'll talk about the importance of probiotics in our life. But you will really see that this first session is absolutely fascinating, with a lot of science, but a lot of practical knowledge to take home that you may not have heard elsewhere. Then we'll have a second module on nutritional therapies to boost the immune system, vitamin A, vitamin C, D, zinc, iodine, a little bit also about iron, and all that practical info. And you will be amazed how efficient zinc is to improve the resistance against virus infections. Almost any kind of virus infections loses ground with zinc supplementation, but also all bacterial infections and parasite infections can severely be countered by zinc supplementation. And we'll see about how vitamin D and the data about that, really interesting, but everything will be focused that you learn exactly what you need to do and what doses to give and what is the safety guidelines. And then we have also the third session will, the week after, will be thymosin alpha-1 and thyroid therapy. And even today I was working already on thyroid therapy, different, how it influences natural killer cell activity, how it influences the other type of lymphocytes and T cells, how the influence on monocytes and on macrophages and on the neutrophils, how different the effects are, and how you can better, by this knowledge, know how efficient the therapy will be in a patient. Thymosin alpha-1, surprising, we'll talk a bit about now later, is really, for me, the #1 immune stimulating therapy in the world. And the higher the dose, the more efficient it is. And I'm taking thymosin alpha-1 every day, also for that reason, so I don't get any infection for the moment. no flu and no COVID-19. Infection 4, cortisol and DH therapies. Amazing that cortisol is really something we need. You and me need to have cortisol deficiency supplemented in our patients and ourselves if we have it. Because it really is very important. And in case of infection, you need to increase the dose very quickly. This will be talked about, but without DHEA, cortisol is dangerous. So you need to supply DHEA at the same time. And DHEA has also very good effects against viruses and other types of infection. And this will have a question and answer session at the end. And then we'll have the fifth session will be on melatonin, growth hormone, estradiol, progesterone, testosterone, and vasopressin. All these therapies have some usefulness in our immune resistance. Just to give you an example, it's impossible in a female mouse to make a female mouse get HIV, even if you put the HIV virus in the vagina, if the female mouse has enough female hormones. But if you take out the ovaries, then the penetration is immediate, and very, very severe infection they get. So basically, the thickness of the mucosa is extremely important to fight off virus infection, and probably this is also the case for the COVID-19 and the coronavirus that causes it. And then we'll have a session on inflammation, on dietary, environmental, nutritional factors. It's so long. There's so much information that this session is longer than 2 hours, and we need that to have. And the first session also will be more than 2 hours when it's cost about nutritionals and things and dietary. But really, this session needs a lot of time for us to be able to do it in details. And an easy way. Then thymosin, alpha-1, thyroid, and adrenal therapies. This is the second. We'll talk about what these hormones can do to calm down inflammation, because inflammation ages us quickly, and if people die from COVID-19, it's often due to too much inflammation, what is called a cytokine storm. You will be amazed how hormone therapies can help to get safe levels of pro-inflammatory cytokines, and often reducing them and blocking any excess secretion, so that doesn't have any adverse effects. And then you have also a session on melatonin, IGF-1, estrogen, progesterone, and testosterone therapies to fight off inflammation, especially on genital areas with testosterone. Very, very efficient against inflammation there. And we'll have a question and answer session also here. So let's give us some example in this session. What are the 2 best treatments that make you survive severe COVID-19 infection? This is the COVID-19 virus, you see, with all those proteins getting out of its surface. Well, 2 hormone therapies, thymosin alpha-1 and cortisol, restore health and can keep COVID-19 patients alive. And we know this already since 2003 for the COVID-19, is that another coronavirus that was very infecting and very deleterious to people, the SARS infection, the severe respiratory distress syndrome that it causes. Basically, you see that in a study on 41 SARS patients, and much of them received the combination of thymosin alpha-A and methylprednisolone, they could survive thanks to these treatments. So we already had an idea, and the Chinese also had an idea that it could really be helpful. And so they bought over the firm that made thymosin alpha-1, and they did a lot of experiences. And basically, can we now also use thymosin alpha to cure COVID-19 infection? Yes, because this study, for example, on 76 patients, 36 of these patients received thymosin alpha-1 at an extremely high dose. It's 7 vials per day of 1.6 milligrams, so 11 milligrams during 7 days. But these patients were at high risk of dying from. And when we see, basically, we see that 30% death rate was there in patients who didn't get the thymosin alpha-1, the matched controls, and 28% had to be intubated, while none of the COVID-19 patients receiving thymosin alpha-1 had to be intubated. And, but there was only 11% dying. So there's a 63% decrease in death rate with thymosin alpha-1. Really, really something very helpful and extremely safe treatment. You cannot die from getting too much of thymosin alpha-1. Really extremely safe treatment. And how did it help these patients? Because thymosin alpha-1, immune-stimulating hormone, increased the lymphocytes again that they had not enough, and they stimulated one type of lymphocytes, the T cells, that were exhausted in these patients. They become reactivated and energetic again. And can it also help to give thymosin alpha in order not to get the COVID-19, that you don't have to wait till it's too late, almost too late to take it? Well, yes. If all those, the medical support team in China, almost not many of those died. And actually all those medical teams that took thymosin alpha-1, they never got a COVID-19 infection while they were a lot in contact. And so it might, it's very likely that if they didn't get any infection, not only because they were careful, but because they took thymosin alpha-1. So if you take it, it also can help you to prevent having it. We should put almost everybody on thymosin alpha-1, and I bet that we don't need to do confinement. What can cortisol do to cure from the COVID-19 infection? That was the other hormone. Well, we saw in a study here that was published in July, but basically that was already, we had some knowledge of the results end of May as for the other study. This group in UK actually saw that there was 1/3 of risk of dying in critical ill patients who were on mechanical ventilation. Those are the most severely affected and the most at risk of dying. And those who were just on oxygen therapy, and so they had 20% less risk of dying. But on patients with less severe case COVID-19 that were not on oxygen and not ventilated, didn't really make a difference. And this is quite a high dose of dexamethasone that was given at 6 milligrams for 10 days, so it's supraphysiological doses. Without DHA, so I think it probably would have a better efficacy if they had received. But you see, for example, the red line is patients with, this is the mortality rate. You see that those with dexamethasone, art parchments, they had lesser mortality, and that there was, especially in those who were assisted with mechanical ventilation, a big difference. And then the mortality was also lower in those who had oxygen only, but not in those who didn't receive oxygen. So it's really a treatment where those who really are having already pulmonary problems. By the way, it's in two YouTube videos, I had already warned the patients that these two treatments, I prefer hydrocortisone, but it's true that when you have an infection, it's better to take a synthetic derivative of cortisone, that those two treatments were efficient. This was 2 or 3 months before the publication. Now, model 2 is also exciting, and I think you will not leave your seat when you will assist this model that is also 2 months with a weekly session of reversing aging, physical aging therapies. And we will talk about scalp hair loss and the facial aging, and partly also body aging, and also how to reverse the aging of the senses, how you can really improve the vision. And this will not only be with hormone therapies, but also with nutritional therapies, and also to improve hearing loss and taste loss, smell loss, touch loss. So information you never get almost nowhere. And you will see there's a lot to do with all those ecological molecules or natural molecules that we have in our body. You just correct the deficiencies and you get often better results than you can get with chemically artificial drugs. Although I'm not an adversary of pharmaceutical industry, because I really think they are doing very often genius things, I think we may not forget that our body's own molecules are important to supply. And so we will have also an overview webinar somewhere in November about that. That will talk about the 8 video sessions we have. The first session being really about what diet can do to make you physically younger or prematurely aging. So what to avoid and what you take in the diet. Also how to reduce pollution, electromagnetic fields can make you also aging. We'll get of some of the scientific facts because too often a lot of information given out without any scientific basis. But don't forget that all this training program is based on evidence with extremely a lot of practical things, but also hard evidence so that you can also justify your treatments. Nutritional therapies will talk, lifestyle changes, etc. And then we'll have the first session on hormone therapies. That will be the second session of this model. The basic hormone therapies, what they do, the thyroid, the adrenal hormones, the sex hormones, vasopressin, and we'll get also some of the dosing and how to do. So we're trying to educate the physician here with being directly into the main practical things that the patients are complaining of and want to improve, so that you are immediately able to treat already problems better than ever before. And we'll have then systemic and topical therapies with growth hormone, IGF-1, insulin, relaxing MSH. We'll also talk about creams, hormone creams, what they can do to improve or to decrease aging and to reverse aging, because this is really the topic of it. Then we'll have a session on reversing the aging of the 5 senses: eyesight loss, hearing loss, tinnitus, those buzzing ear, sizzling tones you can have with age in your ear, taste and smell loss, touch and scent loss. All of these things can be reversible or at least improved. And then we'll have also some on seminar on scalp hair and things like that, and systemic and topical hormone nutritional therapies to recover hair. You will see that almost any hair loss can be reversed and improved with treating the cause and not just the consequence. Treating the cause that is often a hormone deficiency, but it can be also a nutritional deficiency or combination of both. And then we'll talk about face and skin, how to reverse the aging of the face, the wrinkles, the forehead, the crow feet wrinkles, the nasolabial wrinkles, the eyebrow thinness loss, the droopy eyelids, age spots or eczema, and things like that. So really very practical session where you know what to do for it. Then we'll have a session about neck, chest, and abdomen and back aging, and we'll look at all the different things, also how to treat cellulite efficiently, and much more than just weight loss, and reversing bloating belly, obese belly, droopy belly, the sagging skin, etc. We have solutions for that, and this will be taught and taught here. Then we'll have a session, and that will be on the final session. So it's a final session. We'll have a question and answer session at the end about how to reverse back aging, the muscle loss in the back, the sagging skin, the pelvis, the droopy or fatty buttocks, how to reverse it, genital aging also in men and women with Peyronie's disease reversal, varicose, prostate hypertrophy is a reversible situation. And we do have treatment. Sometimes we need to treat locally with the hormones or with the nutrients. And also for women, vulvar atrophy, lichen sclerosis, breast cysts, what to do will be talked about here with some of the scientific studies. And then we'll have, let's give us some example in this session. What are the 2 hormone therapies that are most important to reverse physical aging? Growth hormone treatment, growth hormone and IGF-1, or I'll put them in the same, and testosterone therapy is among the 2 most important treatments to reverse aging. And it's basically physical aging. Testosterone therapy also includes given to women. And testosterone therapy on its own won't help so much, but when you associate growth hormone and or IGF-1 therapy, it works much better in reversing aging. So growth hormone therapy and reversing aging, where is growth hormone produced? Well, it's produced in the pituitary gland. 40% in adults of the anterior pituitary gland, which is so important, is actually of cells that secrete growth hormone. So it must have an importance in adults. It's not only for children, not just the kid stuff. And you see that, for example, this man is well proportioned on the left, but on the right you see that he has had pituitary removal for pituitary tumor, and he was supplemented with all the hormones except growth hormone. And you see how he prematurely ages, although the other treatments are okay. So this difference is the lack of growth hormone. And so don't stay with the growth hormone. How many people don't look like the slide on the right? People with growth hormone deficiency, of course, you almost don't need to do a lab test to be that, but be sure the lab test will confirm it also. And I always do it because it's better for a physician to get good laboratory tests. And so we see that the treatment is with growth hormone subcutaneous injections. We'll talk in the session always practically, so we'll talk how to inject. You must extend the skin, not pinch the skin. Absolutely important not to pinch the skin or you get a blue spot. So how it's shown on internet is generally the wrong way. And so when you have a man who receives has growth hormone deficiency, this was one of my first patients. And I included him in a study of 31 patients that I published and later, already a long time ago in 1987. And 2 months of growth hormone and 4 months of test, look the difference. He looks much younger. The hair has more volume, for example. The eyelids are droopy eyelids that were much less droopy. Are just 2 months of growth hormone. Really, growth hormone that had the biggest effect. And then you see also that the sagging cheeks with the nasolabial folds actually are clearly decreased here. So when you have an aging skin, aging looks with a small epidermis, and you see that the epidermis gets much thicker, younger skin, and that's typically the effect that growth hormone can have. So before and then growth hormone during 2 years, see the big difference. This patient, there's a disappearance of the obesity in this patient just by growth hormone treatment. Really important. Of course, the dose is relatively high. There were some big deficiencies, and people with obesity, much of the fat tissues absorbs the growth hormone and neutralizes, so you need to give high amounts to get good efficacy. This was with 2 units, international units a day, which is about double the physiological dose. So basically, humans have made an amazing progress. This is mankind. And you see that basically this subject has adequate growth hormone. Okay? Now, in just 1 generation time, we have made a miracle. A miracle. We have been made a new Homo sapiens that is actually with growth hormone deficiency. You see all this obesity, etc., with the wrong food that decreases the growth hormone levels. Growth hormone levels can be decreased by alcohol intake, by caffeine intake, coffee intake, by sugar intake. So basically, we don't have the good food. The westernized food is really a growth hormone deficient diet. And what can testosterone do for reversing aging? Well, testosterone, you know, is mainly made in men in the testicles. And basically, transdermal testosterone and intramuscular are mostly the best forms to treat. You can also have pellets of testosterone, was highly efficient in the men who don't want to do too often a treatment intake. So basically, you can adapt to your patient needs, but it usually has to be a way that it penetrates well. The oral way is not the best way. And we'll show that what testosterone can do is also reverse male pattern baldness if it is applied with oral finasteride, so that we decrease the conversion of testosterone to dihydrotestosterone, makes you lose hair, and keep high levels of testosterone. And then you can get the hair growth back. This typical image you can get when you do this, and we'll talk about what type of cream can also be locally applied to improve the scalp. You see that sufficient testosterone gives a voluminous vertex scalp hair regrowth. And IGF-1 does also this. And when I took IGF-1, I can tell you my hair thickened very much, doubled or tripled in volume. Aging, and with aging, you see men age, and part of that aging is really due to low testosterone. You see that on this side, that actually the man here has very low testosterone compared to what he had when he was a young man. So much of the aging of men is due to testosterone deficiency in association with growth hormone deficiency. They have a sort of synergetic effect, these two hormones. So testosterone deficient man, testosterone and DHT rich man. Which are the one you really want to be as a man? I bet you want to be the one who has a firm body, but you need for that to correct your testosterone deficiency if you're already aging. You see that the levels of testosterone decrease with age, and that the aging starts around 25 years of age, and then the levels decrease, and actually after age 25 levels start slowly to become too low. And then the body, who has been shaped for bigger body, much more muscular, is suffering from testosterone deficiency. So we need to be an optimal height level here, for example. All these levels here are testosterone deficiency. You see also people who become more and more obese. Well, obese people with metabolic syndrome, meaning they have high blood pressure, high sugar level next to their abdominal obesity. Well, that's actually testosterone deficient men. So please supply testosterone. Without testosterone gives them a bigger, fatter body and flabbier. Health is based on a firm body. If your body is not firm, you've been neglecting yourself. You've not been taking the right amount of hormones, if ever you are taking hormones. So you see that these are levels that decrease with aging. From the left to the right, we have a slow decrease with aging, but you have people with lower and higher levels. And the lower you are, actually, the more there's a risk of having metabolic syndrome. If you're on the upper limit of testosterone levels, with high testosterone levels, your risk is about 12 times lower than in men having a low level, still within the reference range, but still low level. So testosterone deficiency, when you give testosterone, you can improve the body. But of course, you need to have an adequate food also, and probably to have enough growth hormone to do so. So we'll have then model 3 will be the first basic hormone therapy program, but you will see that it's not just so basic. In the sense that we will see here, it won't be in men. We've changed about topics, but basically we'll talk about estrogen deficiency in excess in women, progesterone deficiency in women, and then also what the deficiencies they are and what treatment to give to women with previous breast, ovarian, endometrial, or cervix cancer. You will see that there, and we'll try to have we'll normally have an international authority that will be leading the session. I will be more like a moderator. But basically, that will be really top information and something not to miss because you can do a lot of good. And you see, this is the overview of the whole training program, Model 1, with an overview that will be somewhere in January of next year, 2-3 weeks before. And we'll see that there will be female hormone deficits. We'll talk about how to make the diagnosis, the deficits, and what are the association when you have low levels with disease like cardiac disease, osteopenia, rheumatoid disorders, and so on. And we'll talk about some exciting things about birth control pill. Is it really so safe, or do we have a bioidentical hormone pill alternative? Really something you would like to know. And then we'll talk about the treatment female hormone therapies, transdermal versus oral, bioidentical versus non-bioidentical. We'll talk about the numerous placebo-controlled studies with female hormone therapies. And we'll talk also about the nutritional supplements and lifestyle that can improve the hormone levels. And then we'll have a third official session of the training program, where all the problems that typically affect women, like abundant bleeding, premenstrual cycle disorders, fibroids, breast and ovarian cysts, polycystic ovarian syndrome, PCOS, endometriosis, lichen sclerosis, cystitis, vaginitis, and depression, etc., anxiety disorders, hypertension, how to adapt the treatment to these patients, how to make that these problems may possibly with female hormone be improved or even cured, and what to do in situations of sports or high intensity sports that is in a regular pattern done. There are many things you can do, but what it will be also exciting is that we'll repeat that women not only need to have female hormones from menopause on, from 50 years on of age, but long before. That may start at 30 years. And then we'll talk about here, it's not female disorders in women actually here. In the last model was question and answer, so it was an international authority where we'll talk about what to do with genital cancer and what doses, what are the benefits, what are the risks, what are the limits, what is the caution to do, really things that physicians need to know when they prescribe these treatments. Examples of, well, how can women feel better and be more alive? They're by taking on time 2 female hormone supplements. And these 2 female hormone therapies is estrogens and progesterone, and they restore to women not only their energy levels, but in some women they feel their life is back and their femininity is back. So basically, it's things that can have sometimes impressive improvements already long before the menopause when they're given. And how frequent is the female hormone deficiency? It's quite frequent from age 30 on. You see in this study showed that there was a progressive, slow, and significant decrease in the levels of the female hormones, estradiol and progesterone, and even in the pituitary hormones from age 30 on in this group of Australian women. And that you don't, and this is the luteal phase, that you don't have the fish that just appear at the menopause. No, long before, slow decline and progressive. And it's better and these are women who had normal menstrual cycles, 28 days. So you don't need to have shorter or longer cycles already to be deficient. And you see, for example, these women are deficient in female hormone therapies. She's good. Here she starts to be, she's still in premenopause and looks already a bit older. And part of that older is because she's not treating her female hormone deficiencies. And then postmenopausal woman, it's pure negligence. A woman who does not take female hormone therapies has to be somewhere educated to take the treatments. It's really worked. It does not increase the cancer risk if the woman does not have painful breast before at any time. That means there's estrogen predominance if there's painful, swollen, and tender breast. And if there's no estrogen predominance, it's quite safe treatments. But we'll talk exactly what to do to make it safe. And you see here, this is a woman on the left before pregnancy, and then after pregnancy, she ages because she has a slight progesterone deficiency. You can see that her eyes don't shine so much, that her hair gets flatter, and her face is paler. And all these women after pregnancy, they have slight estrogen deficiency. You can see them. Maybe don't sleep enough, so they're not gonna make less female hormones. But anyway, the pregnancy itself gives a certain burden of female hormone deficiency. And then you have, if you have sufficient female hormones, women have actually well-developed breasts and feel healthy and more alive than other women who don't have that condition. And you see that when you look at the breast, you have puber stages where the breast size progressively increases until full female hormone development. And an adult woman who's still in the first 4 stages has actually estrogen deficiency. So in adulthood, you need to go to the 5A and the 5B stages here. You see, these women actually have too small breasts. They are estrogen deficient. They're beautiful women, but it's not enough. And the breasts, when they're droopy, they're sagging, actually, that's when a woman had enough female hormones, her breast development was fine, but then suddenly it has decreased. So we'll see to learn all these differences so that you can know when it's necessary. So we should keep the women's breast beautiful and young with female hormone supplementation and not with surgery. Surgery should be a last resort treatment. So basically, with the surgery, you treat just the breast, but basically you don't treat the rest of the body, the pale look, the dry eyes, the flat hair. That is when there's female hormone deficiency. And chronic fatigue and burned out will be in model 4, the topic. And there will be therapies to prevent chronic fatigue, and we'll see all the different types of fatigue people can have: the morning, afternoon, evening, at rest or at effort, during efforts, or in stress. The background fatigue that is there the whole day, or when there's real exhaustion. People never anymore seem to recover, whatever long they stay in their sleep. There are hormone and nutritional deficiencies behind it that by treating it can restore the situation. So here we'll have a first overview webinar, and then we'll see in the first webinar, the dietary nutritional therapies of fatigue. We'll talk about magnesium, coenzyme Q10, vitamin B, C, fish, linseed oil, and so on. And we'll also talk about in the diet about difference in energy of paleo diet, ketogenic, vegan diet, intermittent fasting, and whenever possible, there will be evidence to support the information. But I will still remain practical. In these seminars, we'll give practical information so that you know what to do in your office. And then the second session here, official session of the training program, will be what therapies like thyroid, cortisol, DHEA, aldosterone, and testosterone therapy in men can do to reduce the fatigue. And with scientific studies, practical tips, doses, and things like that. In the third session, we'll talk about other energizing hormone therapies, such as female hormones in women, testosterone therapy in women, thymosin alpha-1, what it does, IGF-1 therapy, melatonin therapy. Also here, and at the end of each session, I'll try to have always a clinical patient case, so you really get into practice with lab tests and things like that. And so you know, this will make it so practical that at the end you'll really be trained to interpret lab tests, interpret clinical signs and symptoms, and be able to prescribe treatments and also know how to solve problems during the therapy. And then we'll have also talking about the burnout, what's it on. We'll see how important cortisol deficiencies in most of the burned out is, but also other hormone deficiencies. And we'll talk about also the need to give nutritional therapies. And we'll have a clinical case of the patient, and at the end of the session, we'll have a question and answer session. So examples that we will see among the numerous slides is we'll talk about 2 energy hormones. And the 2 hormone therapies that can give energy are estrogen and progesterone in women. And no, it's actually here, it should have been, I don't know how the slide came, it should be thyroid therapy and cortisol therapy here. So let's look at thyroid therapy, T4, T3, T2, T1, and T0. And the fatigue of thyroid deficiency is fatigue where you wake up tired, and as soon as you rest, you're tired. But if you move, you feel better. And we know that the thyroid treatment improves the brain, muscle, and inner organ blood flow. It really can increase also glucose metabolism, so it can provide energy. You see all those arteries, we need to have a lot of blood, and there's more blood flowing in the brain and in the muscles when there's more thyroid hormones. And so it can increase also the energy in the heart by increasing ATP levels. and in the heart, and decreasing lactate levels, the acidity actually, lactate in heart arterial cells. So basically, thyroid hormones are very good, and you see that there's the heart rate increases. When the heart rate is increased, you have generally high levels of T3, and basically when there's lower levels of T3, there is a slower heart rate. And thyroid hormones also improve energy by increasing all the hormone productions, such as growth hormone, thymosin alpha-1 is more secrete, more cortisol, more insulin, more sex hormone. And the typical fatigues that are due to all those hormone deficiency also may recover. So if you just have one hormone treatment, it's often enough to give basically the thyroid hormones, because it stimulates all the hormones. But in the ideal treatment is to treat whatever deficiency with its hormones, so giving a multiple hormone therapy. And you see that when you give a combined T3 and T4 treatments, you have actually an increase of more metabolic effects. It stimulates the metabolic effects are better than with T4 alone. So I will repeatedly say that in most cases, but not all cases, it is better to give a treatment with the two thyroid hormones containing it, because you have more metabolic effects actually than with T4 alone. And the reason is that T3 is really the active hormone. We see here that also the T4 and T treatment, this is a study I published, 91 hypothyroid patients treated with T4 alone, and 96% of them suffered from fatigue. Well, basically, of those 96%, 24% had no fatigue anymore after switching from a T4 treatment to a T4 and T3 treatment, combined with the two thyroid hormones. And almost none had no change or worsened. Basically, there's 91 patients, one patient worsened, one patient had no effect, but all the others had efficacy. And another study showed that when patients were treated with either thyroxine or desiccated thyroid, they actually preferred desiccated thyroid, and they felt that the subjective symptoms were simply better, but also they lost more weight. So it seemed that the metabolic effects were better. And this is typically this patient who has had the generosity to give her pictures on the internet, and is often taken an example. She was on L-thyroxine alone for 2 years and looked much more swollen and obese. Well, after 3 years on T4 and T3, she looked really very handsome and slim. So basically, I really am very, I find it privileged that, and a lot of gratitude for these people who tell on the internet, show their pictures with what our treatment gives as efficacy. Now, cortisol to increase energy, cortisol is made by the adrenal glands that are above the kidneys, and it's either by identical hydrocortisone therapy, or you give a synthetic derivative. That's second choice. For energy, the natural bioidentical hormones are usually better, and this is also the case for cortisol. Cortisol or hydrocortisone are synonyms, so when it's in the pharmacy, cortisol is called hydrocortisone. And then there's also methylprednisolone, which is third best for energy. So if you have a graduation, patient is tired, if the patient has no high blood pressure, you might prefer hydrocortisone, but if the patient has high blood pressure, it's more methylprednisolone. And if in between, when there's more rheumatoid disorders, prednisolone might be a better choice. Now, there's a golden rule that has to be respected, that almost never is respected in scientific studies, is that you need the adrenal glands, they make next to cortisol, DHEA, and DHEA must be given in any glucocorticoid treatment as a protection, or if you don't, you should at least give other anabolic hormones, but never give cortisol, a catabolic hormone, alone, or you can stimulate premature aging. So it's very important to know that in the dose of DHEA are equivalent to the dose you would give of hydrocortisone, 20 milligrams. Hydrocortisone, you usually need to give about 20 milligrams of DHEA to prevent any side effects from the hydrocortisone. Now, what sort of fatigue is there with a cortisol deficiency? It's a flu-like fatigue. And when you have the flu, you actually have adrenal deficiency because the flu virus blocks in the pineal gland the secretion of a hormone that stimulates the adrenal glands, SHGH. So low SHGH, low cortisol. And it also will be a fatigue in stress situations and afternoon, evening fatigue. And the chronic fatigue syndrome, it has been shown that they usually have, especially in the evening, low levels. So they're more tired in the evening for this reason. And they have 24-hour urine of a whole day, about 40% less secretion of cortisol, especially patients with burned out are that. And that's probably the main hormone deficiency behind burnout is this low levels of cortisol. Cortisol is really a hormone that provides energy by stimulating blood sugar levels, and they increase blood levels by increasing ATP levels, also by increasing dopamine activity. So they work on a lot of sides: more sugar, more ATP, more dopamine, and more higher blood pressure. So when you're not treating a cortisol deficiency, you're getting problems all there. There will be low blood sugar, and there will be sugar cravings. There will be low blood pressure, so there'll be drowsy feeling in the head because there's not enough blood coming in the brain. So there are a lot of information about that and references. You see that cortisol, increased ATP glycogen levels is one of the references. It really restores in the rat heart, for example. There's more dopamine receptor levels by glucocorticoids, and when you remove the adrenal glands, you have low dopamine receptors. This is why there's lower dopamine activity in those patients. And when you give hydrocortisone therapy, you improve the chronic fatigue syndrome. These are chronic fatigue syndrome patients who first had a month with placebo. And the placebo seemed to have some efficacy, 13% decrease in fatigue score. But when hydrocortisone was given, 29% decreased fatigue. It was more significant. And almost 30% of those patients had no fatigue anymore. They had the same level, score level as the normal subjects. So also a question that is frequently asked, I don't want to take cortisol because I'm going to inhibit my adrenal glands. Well, you do have an inhibition when you give 25 to 35 milligrams a day, but it's transient inhibition, and that as soon as you stop, after a few weeks, it comes back normal. But if you give just a dose of 5 or 10 minutes, there's absolutely no inhibition, but that's not enough. Hydrocortisone minimum dose is 15 milligrams, or there's no good efficacy of the treatment. And then we'll look at module 5 that will be about thyroid supplementation, and I will look at hypothyroidism, autoimmune thyroidism, and hypothyroidism. This will be an in-depth presentation like you probably never had. You probably have heard a lot about presentations and some aspects of, but here we'll have everything together in a very interesting way with a lot of scientific, but again, focus will still be on making it practical and really making it passionating. There's no educational program that works well if there's no passion. And you are there sitting in your seat there, you really need to know that do everything with passion. If you don't do it with passion, skip that. But when you do it with passion, you go much further. You don't get tired easily, and you have a better insight as a physician. So this is really, I will stress out to make it so interesting that you won't stop listening to the presentation. And you really want to know even more, probably, although you will be also is a lot, but I'm trying not to overwhelm you in all the presentations, that you really remember what is important, what to do and not to do, etc., what dose, etc. So we'll have an overview webinar that will be free for everybody because we need to spread the information all over. And so you can know if you're interested, you can always register for just one module if you want. But I think if you register one module, you will want to register all the modules. So will be how to do diagnosis of hypothyroidism will be first session, medical history, hypothyroid science, lab tests, and also we'll talk about lab tests within the reference range that they still can be pathological linked to disease actually, and even higher mortality. So you need to be at optimal levels within the reference range. So we'll talk about that, and I think you will really like this information. And then in hypothyroidism treatment will be the second. We'll talk about all different forms of treatment, but we'll also talk how to solve treatment problems, how heartbeats and ever that can come, although the patient still has hypothyroid symptoms. Why is that so? Well, also we'll have a case of a patient, so you will be really into the practice directly. This is a training program. It's not a theoretical, dogmatic information giving. We really want to get into where you will be helped in your practice as physician, and that you want to treat yourself also and not only your patients. So then will be adjustment of thyroid therapy to disease and overall, to cancer patients, anxiety disorders, cardiac disease in general, children, old age, etc. Really interesting information. And then we'll have one session that will be in depth, and I've made an article of this in the Townsend letter on, published in two, so big, so that was published in two of those Townsend letters. And we'll talk about Hashimoto's thyroiditis, Graves' hypothyroidism, current case of patients, and then a question and answer session. So please ask your questions then. This is really interesting. And then the examples is that we'll talk about one of the features is that thyroid treatment is a key therapy to improve post-COVID life by making us more alive in many ways, including by stimulating the heart. And you know that some of these COVID-19 patients who die actually because the heart is really damaged by the disease. So there are two thyroid hormone therapies, there's T4 and T3. And the T4 provides a continuous supply of T3 when the T4 to T3 conversion is adequate. But there are so many current circumstances where this is not adequate. And then there will be a T3 that will be active, is the active hormone. So basically, these are the best preparation, I think, in the world. I'm not having any links with these producers, but basically, we'll talk about the best working products. Also, pharmacy compounded thyroid can be one of the alternatives. And then we'll see that you have T3 cytomel and Thiromel, the T3. We'll talk about all those different production preparations that are on the market, and they will also on thyroxine only, because there is sometimes an indication to give it too, but it's not as majority are doing now. And let's look what thyroid hormones, they give you a slim face, firm face, not swollen. And when there's not enough, like in this, you have hypothyroidism, you have swollen eyes and swollen pale face, thick lips, and things like that. So basically, you see the lower lip is thicker here, is typical for low thyroid function. And our famous, the most famous painting in the world shows hypothyroid patient. So we'll look in auto details that shows it, and you can look it over. But basically, you see that she has swollen lower eyelids, she has a lack of eyebrows, typical sign. She has losing diffuse hair loss, apparently. She's pale yellowish, which is typical accumulation of beta-carotene pigmentation when there's low thyroid, and so many other things that we'll see in detail. So you see, this is before and after. These are pictures that the photographer of my great-grandfather did, because in our job, basically in our family, it's already 4 successive generations we're treating hormone deficiencies, and mainly thyroid therapy. So I can tell you that I've almost inherited a lot of good and practical information from my predecessors, and I'm really have a lot of gratitude for all these doctors that preceded me to have given me their passion. And you see, this is an untreated hypothyroid patient, and this is a treated hypothyroid patient. This is the kind of changes you have and you obtained. But now let's go back to the heart therapy. We saw that thyroid treatment may be probably the #1 therapy for coronary heart prevention, maybe, but at least is a high position in the options we have there. But it cannot also provide in cardiac disorder. It has to be given at lower doses. So here's studies that show you that basically there's much more coronary heart disease and all-cause mortality in patients who have a high TSH, which is signing already of a degree of thyroid deficiency. And here are references. And you see that in myocardial infarction, there's systematically a lower serum T3, and it's not that protective that you would believe or that we've been taught. And it shows you that the lower the serum T3 is, the greater the heart infarction size is. So basically, you see all these associations for myocardial infarctions, a lot of references. And so what is the effect of thyroid therapy to prevent or recover from cardiac diseases? Is you see this is a study showing that thyroid-treated patients compared to normal population has almost no occurrence of new ischemic heart disease. No patient developed coronary heart disease during their thyroid therapy. That is follow-up of about 5.5 years here, an older study. There were some who developed, but almost nothing compared to what the general population should be. And so there are many other studies. So for example, this study shows you that basically when you give enough thyroxine, and that's a dose of 150 micrograms per day in hypothyroid patient at coronary insufficiency, atherosclerosis of coronary arteries, almost none had further progression of atherosclerosis. But if you give a dose that is 100 micrograms or lower of thyroxine, and I see many patients being treated with that low doses, well, then you have 100% progression of atherosclerosis. And we show also that T3 therapy, T3 and not T4, we were talking about T4, that it actually improved coronary heart insufficiency and myocardial infarction. So we give when in experiments a dog or a pig or a rat received had myocardial infarction, you give them T3, it decreases the damage. So it's much safer than we think, the T3, but we still need to be cautious. So thyroid treatment require caution with use of lower doses, and this is the case for hypertensive patients. You need to start at lower dose in these patients, in older patients too, in angina pectoris, patients who have heart pain regularly. In patients with heart failure, you need to start at lower dose and slowly increase. And an acute myocardial infarction, you often in this case may have to stop the treatment for 2 days if the patient was on treatment, and restart at 50% lower doses. And if the patient was not treated, maybe wait a certain time before treating. And after 2 months, you start at lower doses to treat. So basically, there's an adaptation, onset myocardial infarction, etc. Now, let's look here at model 6. And there's still one other model to talk about melatonin supplementation. And if you feel a little tired on listening, then please relax a bit, move a bit your hands, shake up your head so that you feel that your blood flows again. Because the information I'm giving you, you need to know. As a physician or as a patient, you should really get that information. If you have a glass of water, do like me, drink a little bit water. Now, melatonin, you think, is just something to sleep, and there's almost nothing to say you're wrong. You're right when you think there's a lot of undiscovered things, and you're right when you think there's a lot of things that have been discovered and a lot of application, because this is a real safe treatment where you can help a lot. So not only for sleep, jet lag, shift work, but also for cardiovascular disorders, for cancer, also for inflammation and infection. It's an anti-inflammatory hormone, melatonin, and for longevity also, and so much more. And there's so much information that even 4 sessions of 2 hours may not be enough. And you will be bombarded by practical information that you can apply in your office. So basically, it's really interesting to attend to this seminar. So we'll overview this in an overview seminar session 2-3 weeks before, and then we'll go to the diagnosis of melatonin deficiency, the high frequency of deficiency, and we'll talk about this here a little bit more. Lab test interpretation, what are lab tests to do, and the association with age-related diseases, and we'll have a clinical case of a patient. And then we'll see the second session of 1.5 to 2 hours will be on how to treat melatonin deficiency, not also with a better lifestyle, environmental light, and being away of electromagnetic fields, giving nutritional supplements, and also giving precursors of melatonin treatments, sublingual or oral, and overcoming pitfalls and how to adjust to jet lag, because it's not the way they usually say. You really have to take melatonin just before bedtime when you arrive in your new country, and not 3 hours before. And also the enormous and interesting amount of placebo-controlled trials. And then we'll see also in how to adjust melatonin to diseases, because it's really something you might have to take much higher amounts in some diseases, like cardiac disease, osteoporosis, cancer, depression, anxiety, how to adjust. And sometimes you have to lower the dose. You need to know all this. So we'll give a whole lecture on that. And then we'll have, with normally an international melatonin authority, we'll talk about its antiviral actions of melatonin, the anti-cancer actions of melatonin, the actions on longevity, so that your passion will be there and you will want to ask a lot of questions and answers. And let's look at the melatonin supplementation that can also make our post-COVID better. And so what are the doses for daily needs, and what doses, or how to increase the dose when you need more? And you need to give daily doses that are often very small, much smaller than is generally told, and that have to be sublingual preferably, to sleep better and prevent disease. But once you have a disease, or you have a jet lag, you need to take much higher amounts, and we'll talk how to do it safely. And I want to remember you that melatonin is most probably a 3 billion year old existing molecule. It's presented in the earliest life forms. It's found in all organisms, bacteria, algae, fungi, plants, insects, vertebrates, and also in humans, but also other mammals. And there's no life form where melatonin has not been detected. So it must have something very important for survival. And you see, this is the bacterium, Rhodospirillum rubrum, that was, it's about 4 microns, and it has melatonin in it. And these fossils of this bacterium have been found from that were more than 3 billion years old. And flowers, leaves, seeds of plants have melatonin. And the highest plant melatonin levels are in white and black mustard seeds. There's much higher melatonin level than the known physiological concentrations in the blood of many vertebrates. So basically shows you how abundant it is in life forms. Where's melatonin produced? In the body, in the pineal gland, that is here. As most melatonin is produced in pineal gland, and at night there are 6 times higher levels than during the day. But during the day, what is produced is actually produced in our by our intestines. Intestines are fantastic producers of melatonin for their own use to neutralize the oxidative stress caused by the food that is eaten. There's now, it's a basic principle that melatonin deficiency is almost in every person. This is how the world looked like at night from the sky more than 200 years ago. The world was much darker than now. This is, you see that at night you make much more melatonin, high melatonin level, but during daytime, very little levels. It's the opposite of cortisol. Today, there's excessive light at night is probably the first cause of melatonin deficiency. You see all these lights? In Europe, it's almost completely lightened from the sky. In the United States too, and all near the coast of South America. And look at India, a lot of light, and Asia, Japan, China, Russia. So no wonder there's melatonin deficiency in a lot of people. Now, melatonin treatment to prevent and reduce cancer is associated with low melatonin levels. And here I'm giving some of the slides, but there's much more information. Here, for example, in lung cancer, significantly lower salivary melatonin levels and a flatter slope. And in breast cancer, women with breast cancer have low serum and urinary melatonin levels. And women who have high levels of melatonin urines have 22% less risk of breast cancer. So it should be protected. You see all these studies showing association of breast cancer patients, that breast cancer have lower melatonin levels, and also in review studies. And women with ovarian cancer also 2 times lower serum melatonin levels. You see that here on the right, upper right, you see that ovarian cancer have lower melatonin levels compared to 2 times lower levels. And prostate cancer states have 5 times lower serum melatonin levels than patients with prostate hyperplasia. So the abundance of all these different studies suggests that low melatonin levels may promote cancer development. You see that melatonin treatment reduces cancer growth, and what the dose should be if you really want to for prevention, sublingual 0.1 to 1 milligram per day at bedtime. But once you have cancer, you can go between 10 and 180 milligrams per day of oral melatonin in 2 or 3 divided doses without any danger other than sleeping more. So don't drive the car then. And you see that, for example, glioma cells in vitro, melatonin can decrease the growth of glioma cells in vitro. Glioma is a brain tumor. In thyroid cancer, and also in vivo and in vitro in mice, the thyroid cancer can be suppressed or significantly blocked by melatonin. Also in vitro, lung cancer cell growth is blocked by melatonin. You see all these lung cancers here, cells. And liver cancer cells cannot proliferate well if in the medium melatonin is added. And you see also the references that show that kidney cancer growth in vitro is actually decreased by melatonin. Also, melatonin inhibits the proliferation of stomach cancer cell growth in vitro. So most of these studies are in vitro. But it's so almost on any type of cancer, melatonin has blocking effects. You see here colorectal cancer, gastrointestinal cancer also, colorectal cancer, all the references. And even leukemia cell growth can be inhibited by melatonin. And so what would the efficient dose of leukemia? Because I have such a patient who they don't understand how better he is. But he takes oral melatonin 10 to 180 milligrams per day in 2 to 3 divided doses. And I do add also nutrients that have an anti-cancer effects like iodine, vitamin A, MSM. We'll see this methylsulfonyl that's sulfur actually. Those 3 are my bestsellers. So I would also add vitamin D, and in certain cases vitamin C also. But basically never forget this and for leukemia. Also, breast cancer growth in vitro. In one study, the melatonin increased 70 times the apoptosis, the dying or the killing of the cancer cells. And breast cancer cell viability decreased by 57%. So basically, all cells died quicker and with melatonin. Now, what would be efficient dose for suspect breast cancer? Also between 10 and 180 milligrams, very similar to what you would give. And I would give also melatonin oil to give on breast tissue. We'll give a lot of this type of information for melatonin. So giving it here because maybe you have a patient who has having a problem, so you might already get to more efficient treatment. All these treatments are adjuvant to what traditional therapies would be given. Of course, I would always propose to surgically remove a tumor. Breast cancer, the improved reduction with melatonin treatment in vitro, many studies in vitro also, you see a lot of studies for breast cancer cells, and there's actually even more. Breast cancer in vivo, there's just one study I found here, but there it was where melatonin improved the sleep of breast cancer patients. It didn't really report an improvement of breast cancer reduction. In here, in ovarian cancer cell growth, also in vitro studies, cervix cancer, also prostate cancer growth. And a warning is that there's mostly in vitro studies showing the anti-cancer effects of melatonin. There's a small number of in vivo studies on animals. There's also in vivo studies usually in association with interleukin-2, and there's 70 studies actually, more than 70 studies showing that melatonin might have had a good effect in terminal cancer patients. But there's not enough in vivo studies to be completely sure of doing anything, but it doesn't do any bad. So basically there's enough that information to say it could be an adjuvant treatment, but doesn't replace the classical treatments proposed by oncologists. And then the final model will be on testosterone supplementation in men and women. And we'll talk about different types of treatment and deficiencies and excess in men, and also estradiol excess in men, and in women, testosterone deficient in women, and dihydrotestosterone excess in women, like hirsutism and things like that. So basically, we'll have a first session on diagnosis of testosterone deficiency with lab test interpretation, nutritional supplements that improve testosterone levels, and always a clinical case patient. And then we'll go on the treatment with dietary and lifestyle adjustment to improve testosterone levels, with bioidentical testosterone versus anabolic steroids. You will have, and that takes a lot of time. So basically, we need time to show all the options you have to treat men with testosterone or testosterone derivatives. And then we'll show how to adjust doses with disease, hypertension, cardiac diseases, anxiety disorders, etc., chronic stress. And also we'll show that age-related diseases often have, in men at least, association with testosterone deficiency. And then we'll have other problems like in the fourth model, the fourth model will be many clinical cases of testosterone deficient patients treated with testosterone therapy. But here we'll try to have an international authority. So we don't have yet the information, but we'll try to have an international authority, and I have enough people, where we'll specifically base the information on prostate cancer, testicular cancer, and what to do, and things like that. So high-level information will be given here. And then we'll have 2 sessions of testosterone treatment and deficiency and treatment in women. And the first will be on diagnosis, associated with testosterone deficiency with age-related disease in women, and how to treat testosterone deficiency with nutritional supplements in clinical cases. And then we'll have dietary and lifestyle adjustments to improve testosterone levels, testosterone treatments with oral, transdermal, intramuscular, and also to adjust the testosterone treatment to disease in women like stroke. And I can tell I have a beautiful case patient to tell. And we'll have a question and answer session at the end of this one. So this is the second session. And let's show what we can have, because testosterone is one of treatments can help with COVID. So we can help for COVID by and being more strong in demand by treating testosterone deficient in men on time and when it's necessary. And in men, we often have to add an aromatase blocker and 5-HT blocker. And I personally take those 2 blockers supplementary, because at my age of 63 years, I am doing what most men are doing, making too much estradiol out of their testosterone, and having a tendency to have more dihydrotestosterone than and lower testosterone. So to protect myself from male pattern hair loss, I was losing my hair here at age 40. Now, fortunately, it's better because I'm taking this finasteride with my testosterone. That's the quick, not finasteride alone, you need to give testosterone with finasteride. Never give finasteride to a man without giving testosterone. We'll talk the reasons why. And aromatase blocker I take also. And women should always, when they receive testosterone, take estrogens and progesterone to avoid masculinization and hair loss. So this is how a man should look like, masculine body. And the problem is that with age, we see a yellow curve that there's a higher estradiol ratio compared to the bioavailable testosterone, while the bioavailable testosterone decreases. So basically, men get about 10 to 30% more estradiol and less than 30% lower testosterone. And this gives this change in outlook. And don't think it's just an aesthetical problem, because this is just the top of the iceberg. There's also a lower health in this person getting gynecomastia. So you see, this is what happens with testosterone. Looks obese with more breast here, much less, more masculine breast with testosterone therapy. So what can, we'll look into details of that, how to treat that, but basically let's give some information. What can increase this estradiol to testosterone ratio in men and make them look more feminine and not men? Well, caffeine. And there's caffeine in everything, like hot chocolate, brewed coffee, black tea, etc. That's always too much. Decaffeinated has some caffeine, but almost nothing. That's okay. So the dark chocolate is not good because it has a lot. It has the equivalent of a coffee cup in 100 grams of caffeine, and it has also theobromine. That's why your heart beats a lot in the evening if you would take caffeine when you're in bed. If you take dark chocolate. So drinking 2 cups or more per day of caffeinated coffee decreases the testosterone and increases the female hormones, gives us feminization. You mimic what age already does. So you aggravate the age-related process. And you have also more female hormones, estrogen, SVG. You all have more IGF-1, T3, T4 with more caffeine and more insulin. So you have an increased fat mass. So don't come at my clinic, because we see a lot of patients and I think it's very good for them. But if they don't follow the food and adapt their food enough, they can counter and block our treatments with this, or make that they even have more female hormones because they receive testosterone. So they need to do an effort here. And we really stress this, and we educate our patients to be better caretakers of themselves. So alcohol has also the same process. It lowers testosterone, increases the estradiol levels, and it also decreases the growth hormone levels, the melatonin levels, which increase the fat mass. So you need to change your diet and to optimize your diet if you want to go on the treatments to get the full efficacy. In women, for example, you see that women have, in 2 years' time, can increase in this women. They had 10% more abdominal fat, intra-abdominal adipose tissue. So after 2 years, among those who were taking female hormone therapy, because this was in postmenopausal women, the higher estradiol was, the lower the abdominal fat was. And among those who didn't take female hormone, the higher the testosterone levels they had, the lower the fat was. So basically, I would say taking testosterone and estradiol can have a beneficial effect to avoid getting an obese body. So we have seen about this model. Let's look at the training program. The training program we are proposing is in collaboration with partners from many countries. And it's, for the moment, it's more than 20 countries: Argentina, Bahrain, Belgium, Brazil, China, in a later stage, Germany, Greece, Hong Kong, Indonesia, Italy, Malaysia, Mexico, Netherlands, Portugal, Russia, Saudi Arabia, Singapore, Spain, Thailand, Arab Emirates, and United Kingdom. And it's a program that is a 2-year training program with 1 year additional specialization, and it is entirely through the internet, online training with live webinars and pre-recorded videos. So the aim is to give a real exclusive medical training hormone therapies, but without also going and look on the diet, the lifestyle, and nutritional deficiencies and supplements, it's not possible to do optimal hormone therapy. And the focus is here to do the best hormone therapy you ever had. And the method is to do it with live video lectures and pre-recorded video lectures. And among those lectures, we have lectures that are followed by a question and answer session. And that's the promotional free overview webinar that I was talking to you about. But also the last session at the month is generally, not all, if you have a longer module, as the last session of the module of the month, has actually a video session followed by question and answer session. And then we have pre-recorded videos 3 per month, but they will be every time put on certain times. So we have a calendar. And once we have done the webinar like now, some days after, we'll have the pre-recorded video available for everybody who couldn't attend the lecture. And the webinar and online trainings are always evidenced and updated almost with the latest. I have 4 to 5 students working half-time to collect the data, and I've already been collecting data since more than 30 years. So basically, we have here an updated program, and it will try to make them updated all the time. If we continue later on, there will be updates constantly, easy to insert by an additional small lecture. So it's always practice and rendered how to do it, and interactive, providing the opportunity for attendees to ask questions during the live questions and answer sessions, to exchange information also eventually. So the target is to do it for a physician as good as practical, so that everybody understands the information. So there will be possibility for other health professionals. And then we'll have the speakers, will be me mainly, but after the first 3 months or 2 months and a half of model, we'll have try to get international authorities. Normally have the agreement, but I haven't the definitive agreement yet. But so they will be exciting to get also the opinion from a world-leading figure in that. And so duration is that one free overview webinar is about an hour with question and answer sessions 2 to 3 weeks before a new model. There will be then every week, the first 4 weeks of the month in general, 1 hour 30 to 2 hour duration. The one model will be generally 1 month. Some will be 1.5 and some 2 months. And one academic year is about 9.5 to 10 months duration. And there will be a postgraduate cycle that you can do after the 2 years. So it's 2 years with possibility of 3rd year specialization. And there's a certificate of attendance for CME and CPD credits that will be given for each registered session. There will be an exam at the end of the academic year for those who follow the whole program. But you generally don't have additional home or office work to do. So this is the training process. The first model, we had an overview. We saw that we ended with testosterone. We started with COVID-19 and went to reverse physical aging. The second model will have an absolutely not to miss session on longevity. What the diet can do to make you live longer, nutrients can do to make you live, and hormone therapies. And there's a lot of very interesting information. And then there will be a 9th model. We'll go really on hormone consultation. You already know a lot, but basically we'll go in depth so that you can assemble all the information to make it really as well known and well understood as possible. And then there will be an oxytocin supplementation model. There will be anxiety and depression, low resistance and hormone therapy, so that you can treat psychological disorders. The main one with hormone therapy, if they're chronic, I can tell you they almost always have hormone deficiency behind it in those chronic psychological disorders. So you can give as much psychological pharmaceutical drugs, but you won't solve the problem if you don't correct the hormone deficiency. And I started as an assistant in psychiatry. I know what I'm talking about, and I have seen so many good results. I want to share that with you, because you are the doctor that can make a change in the life of many patients. You are the hero. You are my hero, because I know that you will really apply the treatments with a lot of ethicals, so that basically the patient really will get better and know how. Now, lipid disorders, cardiac disease, stroke, absolutely interesting to see by not only all cardiologists, but all family doctors should see this. Cortisol therapy, will have a basic instruction about that. DHEA, aldosterone, pregnenolone. Cancer, what diet, nutritional therapies, and hormone therapies can do. How can you treat all these patients that are having cancer with hormone therapies? And you will see that it's often an important part of their revalidation program. Growth hormone supplementation in module 16 and module 17 will be obesity, everything about diet, nutritional, and especially hormone therapies. So you really have an important, you see that in the summer, we have an exam, evidence-based hormone therapy certification year 2 you can do. I must say that basically, as well as now here, is that we do propose a board certification in hormone therapy, and I will give you some information about that, because if you pass that exam, it facilitates really your whole training. You will follow things much better, you will understand better, and go on much higher level of expertise. Then the third year, that is an optional year when you can do sexual optimization for men and women, hormone therapies. This every sexologist should know, but also family doctor and everybody who has dealt with sexuality to sexual dysfunction. This you will find treatments that often work better than what is ever proposed now in universities. And then module 19, vasopressin, IGF-1, HCG therapies, we'll talk about it. Really interesting, because these are some of the important therapies. Then we'll have a module on respiratory and digestive disorders, hormone therapies. Neurological disorders will be in psychosis, hormone therapies. Sleep disorders, practical patient case treat with hormones. This will really very practical model. Then we'll have the psychological attitudes that promote health and longevity, the negative and positive emotions, the psychological attitudes, centenarians, really, really interesting. And then we'll have some about the hormones for osteoporosis, and then some treatments that you may not heard but are very major, like insulin therapy for sarcopenia in non-diabetic patients. And then we'll go have a peptide supplementation model on follistatin, mechanogrowth factor, growth hormone fragment, thymosin beta-4, etc. And then we'll end by a session on diabetes, osteoporosis, rheumatoid disorders, and hormone therapies. So you will really have a lot of information. And what about the CME credits? You follow the models. For each video session, you can get CME credits. But you also need to know that you can follow the models independently. If you just want to have information, one model, the longevity program, for example, you can. Exams, there will be, for those who follow the CME credits, a sort of little control that you really participated. So there will be question and answer session, a multiple choice quiz at the end of every model. So that's okay. And then additional service we can give, you can assist in our clinic here. Maybe we find other clinics where you can also assist if they're close to your country enrollment. You can assist in my clinic, because I think we really have the top treatments here passively. And you can, we also have a hormone hotline. If you want to start hormone therapy and you're not so sure about, you want to be talk 15 minutes, 30 minutes or more with the doctor, you can. You subscribe to the hormone hotline. We also have scientific references and access to an extensive list of scientific references. You can get access of the International Hormone Society. We have almost all the scientific data on hormone therapies there, well organized, and much of it is freely accessible. But for those who participate in a whole year of training program, you get a free access to the more deeper part, which be online normally in a month or two. And then we have a YouTube channel, a healthy aging channel, with some already YouTube videos that can be shown to your patients if they want some additional information. But we also have a channel that exists in French that is much more worked out, called Une Autre Santé. So why should you join us? Well, there are 8 key reasons for physicians to join the program. You there on the other side the screen should join the firm? Well, first, most doctors in most countries need to have continuous medical indication. And you can get the European CME credits, meaning they are valid in the United States and the whole Europe and in many other countries in the world. So you can have your CME credits. You get relevant and fascinating topics. We're beginning with a whole model of 2 months on basic COVID-19, how to treat infections in general, not only COVID-19, and inflammation. And these are really signs that you need to have. Any doctor now, with what has happened with COVID-19, needs that information. So you get also much more familiar with immunology and the science around inflammation, so that you know what you're talking, and it will be shown not in a theoretical, discouraging way, but in a very interesting way, with repeats, with practical information. So you know really what about. You also have reversing physical aging, fatigue, and burnout treatment, etc. Really interesting. We also have key speakers. I think I can tell that I'm a good speaker that is well internationally accepted, but we'll try to have some other international experts. So you have other those people that really bring you at a higher level of knowledge and thinking and of also practical expertise. And then we'll have practical information. You will have solutions for many problems or adfusion treatments that you can give that will make the patient feel better. And then you will have a lot of scientific references, but they won't be shown in an overloading way, but in a way that makes you know what is the latest information and what is the oldest maybe information, but what's really helpful for you. And there will be testing quizzes, so you can be stimulated by doing those little short questionnaires at the end of each session. You can also update CME accreditation, a sort of postgraduate certificate that the Hertoghe Medical School can give you. So it does give you more credit, especially as it's based on this International Hormone Society website that has all this huge data amount of scientific references. And you also be part of a movement, and that gives you a little feeling in the stomach, being a part of many, because we have felt a lot of enthusiasm in those different countries. So you really will get what about the fees? Well, the fee of a unique lecture is more expensive, of course, 155 euros. But if you follow 10 modules, you have 10 modules. It's basically 10 months because there are 7 modules in the first year. But it's 5,500 euros. And because there's this COVID crisis, we have thought it can be something special. For those who subscribe now from actually August to December, there should be actually a lower price. So there will be a lower price. And you have for everything. And one model can be of 2 months is 1,180, or for just 2 weeks model, there's one of 310, and 1 month is 600 euros. So the basic model, 600 euros, well, it becomes 495 euros. And that's expenses you can take out of your tax deduction because it's professional information. And with that is included the fact that you have CME credits. So basically, I think it's really worth. You don't have to go to a congress to get your CME credits. You can get them here. So that makes it also much more worthwhile. And I think this is really worth it. It's a high elite training program that you can enjoy of the discount if you pay now, or you pay in the first months. And if you just want to do one module, you can start with one module, and then you decide you do a whole year. We'll arrange that you get the whole year price. And then what we really encourage you to do is to optimize your learning by passing the board certification in hormone therapy of the International Hormone Society. So what is this formed of? It's based on the hormone handbook and on Atlas of Endocrinology for Hormone Therapy. So you have learning material, and it actually includes the 12 most frequently used hormone therapies: thyroid, DHEA, melatonin treatment, testosterone, female hormones, growth hormone, oxytocin, and things like that. So you really know what you first need to know. And then it's practical. It's oriented towards your practice, always with doses, signs, follow-up. And you have also a test questionnaire that you can do, so you know what type of questions you get. You get also questions for physical signs with a picture. You have to recognize physical sign. You always have a five choices, a multiple choice answers, 5 questions, and you need to choose one of those questions. The time you get them to learn for the material, you need between 60 hours to 220 hours, depending on your degree of expertise already now. But really, this will help you your whole life. And you have 200 multiple choice questions with 30 questions showing a picture of physical exam. This I talked, the exam is 2.5 hours. And most of people can obtain 60%. Well, you need to obtain 60% of correct answers. It's international certificate. I think it's the only international endocrinology or hormone therapy exam, and basically probably the most practical of all. It's easy accessible. You can learn it at home or in the office and do the exam through the internet. And you have it's certified by International Hormone Society, and there's a success rate. 80% of physicians passed at the first trial. So basically, it's okay to do it. So basically, you can also buy more books. And you have the hormone handbook we talked about, testosterone therapy for real gentlemen, reverse physical age. These are really very good books that help you. The testosterone, my latest book, and I can tell you, you get all the information you've dreamed of on testosterone therapy. And so we have also books for the general public, Hormone Solution, Oxytocin, The Passion of Sex and Long Life for Oxytocin, and the Patient Hormone Handbook. So, and now there will be some few words from Dr. Itala Rashid from Lujdat Sawidat, who is one of our best partners and really the one who introduced all these type of therapies like hormone therapies and anti-aging therapies in Brazil. He has, he's done almost all by his own with a fantastic team.
Hello, everybody. I'm Dr. Itala Rashid from Brazil. I'm the scientific director of the Healthy Aging Group, an enterprise dedication to the medical education. Along the last 20 years, we have spread this concept among 8,600 physicians that deal with these hormone therapies in their daily practice. Also, I'm the vice president of the International Hormone Society for South America, and we sponsor every year a congress in São Paulo, Brazil, where we try to bring the best brains, the best researchers in the area that can contribute to the development of the field of medicine in Brazil. And last but not least, I'm very proud to let you know that I'm a very close friend to Dr. Hertoghe. During the last 15 years, Dr. Hertoghe has made a great contribution to medicine in Brazil. And for all these reasons, we are all lucky enough to have one of the most brilliant and the most important physicians in the whole world in the area. Thank you, Thierry, very much for this great opportunity to tell these few words to these people. And I wish you all a great webinar. God bless you.
Screen. Okay, now I have some information to give here next about our partners. So we have a lot of partners, and then we'll have our question and answer session. So we saw that Dr. Itala Rashid talking about longevity at Sadaville. We also have the Saham with Selva Maragazami, who has a lot of importance there in Malaysia, and it's helping us also a lot. We have also help from our International Anti-Aging System, which is sells a lot of products that often are not so available all over the world. And then we have also the Vid Pharmacia Laboratoria, we have Pharmanor, we have Jakarta Anti-Aging Center, we have BioNoriso, we have LIMS, which is a laboratory. Laboratory is CopMed, also who sells nutritional products, tailor-made compounding. We have Dr. Yvonne Murperi, who helps us from Portugal, Laboratoire Réunie from Luxembourg, who helps us, Forthaus Apotheke, who helps us from Germany, Energetica Natura is situated in Holland, sells nutritional supplements, University Compounding Pharmacy, which helps us a lot in the United States, NP Compounding Pharmacy, Vital Plus, also EuroHealth, etc. And NutriEssentiel, which is also a nutritional supply partner. So the next webinar, it will be in October the 6th, and that will be a free overview webinar of the immunology module. And I really propose you to be there because you'll get some really exciting information there. So this is the link to get into this webinar. And you have also for the Hertoghe Medical School, where you can get all the information about the training programs and subscribe. And if you need to have an email, it's office@hertoghe.eu, the Hertoghe Medical School in one word.eu for the website, and for the email, office@hertoghe.eu. I thank you for your attention, and let's go to some question and answer session. So let me see where I can get into the question and answer session. Okay, I have questions here. How much cortisol is to give for cortisol COVID-19? In the study that showed cortisol derivative, dexamethasone, the dose was 6 to 8 milligrams that was given per day during 10 days. This is actually a dose that is for the synthetic derivative. If you would give the natural cortisol, it has been used to save the lives of people with severe sepsis and septic shock, so the real life-threatening situation. And the dose there has to be 100 to 200 milligrams maximum. And I would say not more than 150 milligrams, I would advise, was giving a similar dose of DHA, and it works better. If you go at more than 200 milligrams per day, and intravenous, you may even increase mortality. So you have to stay on this dose. Is thymosin alpha-1 safe for kids? Of course it's safe for kids. Kids have it also, and I'm more used to give it to adults, but thymosin alpha-1 has only given problems locally because you give us with a syringe an injection under the skin, and it gives sort of irritation. This irritation is, I have almost none of my patients ever having it, but in studies it's published that 1 or 2% can get some irritation, and that could be a problem for kids. But it has to be given subcutaneous. If a replay is possible, this will be is there a replay? Yes, possible. Yes, it's possible to have a replay of this. It's in 2 or 3 days. We'll have it on the internet. How much of thymosin alpha-1 for prevention was taken? How much for treatment? For prevention, it's 0.05 milligrams per day. With the official brand is called Sedaxin. It's from in 33 countries registered. It's thymosin alpha-1 from, it's actually by a Chinese firm. But if you take another brand, you generally have to give 2 or 3 times that dose. So I would say 0.1 milligram per day for prevention. And if you have to treat, you have the doses that were given to save the life of people who never had thymosin alpha-1 before were 11 milligrams. So that's enormous amount. It's about 100 times the dose what I'm just talked about. But basically, if you take the good brand and you were taking thymosin alpha-1, you will never need much, and you will probably to take maximum 1 vial a day, and 1 vial is 1.6 milligrams a day during 10 days to overcome basically what I did in patients who are almost dying from COVID was to give the dose of about 0.5 milligram per day during several days, 5 days, and was enough to get them out of the problems with a little bit more cortisol. What is the cardiac risk with using growth hormone? There's almost no cardiac risk with growth hormone because growth hormone if you have a myocardial infarction in animals, decreased by 90% the infarction zone. So basically, it's protective. But there's a small risk if a person has adrenal deficiency, because growth hormone decreases cortisol, and you need for the heart also cortisol. So if a person has cortisol deficiency, and you recognize these people because they have a lot of spots on their face, little brown spots, Addison spots called, or age spots called by others, but then you have to be careful, and you probably need to correct also the cortisol deficiency. What is the dose of thimerosal one can take? I already talked about what precautions to take. There's almost no precautions to take. It's almost tolerated by everybody. I'm a life rule of your biological hormone therapy, which literally saved my life in 2010 for my estrogen-dependent breast cancer. But for some months, the pharmacy in Brussels denies to send growth hormone to Spain. Is there any way to get it in Spain or elsewhere? You actually need to change pharmacy. We have several pharmacies in Brussels that can supply growth hormone to European countries. So it should be no problem, but you probably have to pay a FedEx so you're sure it arrives. If it's arrived by normal post, I wouldn't advise this for growth hormone. Because may avoid stopping marriage, I follow happy. Okay, and thanking you for your kind response and for sharing your wisdom to improve our quality of life. Okay, then here's the question: is this international program in affiliation with University of Canada? We did have prematurely an affiliation with university, but we didn't have a good cooperation with them as they were not very active. So we decided not to give false hope to people with a parallel university, and we're seeking to have, and that will take maybe a month, with an official trustable university. So for the moment it's not, but the program is not with an official university, but we're going to try within a year to obtain that. Doctor, I have patient positive COVID, show low ACTH, low thyroid, low cortisol, low progesterone. What do you suggest for this patient? Well, for this patient, I would suggest that this patient does a better control. Go to a doctor who knows more about it. They can go to our Brussels clinic and have their deficiencies treated, because the COVID destroys a lot of, damages a lot of tissue if you had a severe disease. And you need, and it's with hormone therapies, you can restore everything, and especially the endocrine deficiency caused by COVID. In a recent 19-year follow-up of the randomized Women's Health Initiative, which involves more than 10,000 possible people, the use of estrogen alone significantly reduced the incidence of breast cancer by 23%, contrary to the earlier well-known study. Given these newer findings, should patients still pause their estrogen treatment 5 days as started in the hormone handbook? I think there's always, before this Women's Health Initiative that showed more breast cancer was giving conjugated estrogens, non-bioidentical estrogens with medroxyprogesterone acetate. This study basically, I was already saying a series of things that you need to watch out with estrogens, that you need to watch out with the medroxyprogesterone acetate, because there's much better types of progesterone given. And so basically, I wasn't surprised about the study. Now, this study, I didn't know about it, that the breast cancer was decreased of incidence after a certain time. But anyway, I still think you need to pause at the end of the month, some days, because studies have shown better effects. And so basically, I think if you have 23% less breast cancer risk, why not get 80% less breast cancer risk? And that will be done also by pausing at the end of your treatment. Is there's cette formation existe en français? This French. We have in French. I must say that I forgot to say something very important. We'll have Portuguese, Spanish, and probably French translation at the end of at the lower part of the training program. It's not for this lecture, but from the next lectures on, we'll probably have different language translations, because we do it with software program controlled by people. So it probably will be that we'll have this available in French, but as subtitles in French. We even hope to have it in German, but we're not sure about that. For Portuguese and Spanish, we'll have subtitles, and French probably. you think that the optimization of the endocannabinoid system would make a positive impact in the aging process and COVID-19? I cannot answer this question. I don't have enough information about this alternative form of cannabis use, which is now widely acceptable and has so much major effects. The problem is that all cannabinoid things decrease the secretion of many, many hormones because it blocks the pituitary gland. So I do not think that endocannabinoid system stimulation will positively impact on the long-term aging process because of hormone deficiency. But if you corrected the hormone deficiencies, you probably might have good effects. Optimization. Good evening. Will it be possible to watch the pre-recorded sessions at any time? Will you provide slides? Yes, at any time. For the slides that only will be provided for those who have to register for the program, they will get a copy of all the slides. For a cat that has too high cortisol, giving cortisol to reduce it, should I give it as well DHEA? Yes, you always have to supply DHEA with cortisol, but cats do not have high DHEA levels in their blood. And cats, very strangely, have a very high metabolism, so they metabolize cortisol quickly. But normally, I would still give some DHEA with it to the cat. Do you provide the option of paying the fee for the course in installment or just as one payoff? Normally, you need to pay everything in once, but you can start with the first module and then see and then pay the rest. We always have personalized solutions for everybody, but there must be a specific demand then. Sorry for the cut, but it's possible to pay the fees for monthly or every two. So I think it's the same question. So I think there are possibilities if you really have a problem to arrange a personal adjustment for you. So we're very open because basically we think this is information everybody should have. So we're trying to help everybody. Do you recommend progesterone oral every day, or do patients need to take breaks every 3 months? It's not clear in your lecture. Well, basically, if it's the micronized bioidentical progesterone, you can take it every day of the month without any harm. But the problem is that if you take progesterone without estrogen, a woman may feel tired and even depressed because it has a calming effect. So this is one of the reasons why I pass. I think estrogens have to be passed every month. Progesterone not necessary, but basically, in order to avoid any depression or fatigue, I think it's good to avoid progesterone 5 days a month if you are stopping estrogens at that moment as a woman. Can biologists assist to this formation? Est-ce que des biologistes peuvent assister à cette formation? And also nutritionists. We can allow biologists and nutritionists because they work in hormone therapy. Donc les biologistes et les nutritionnistes peuvent être admis puisqu'ils travaillent dans la médecine. If you are a health professional, we can avoid, but you need to do a special demand. Doctor, what is the proper ratio of cortisol and DHEA when prescribed together in adrenal deficiency? Well, cortisol is actually hydrocortisone, and if you give 20 milligrams hydrocortisone or 30 milligrams of hydrocortisone, you need to give 20 milligrams of DHEA, 30 milligrams of DHEA approximately. If it's a synthetic derivative like prednisolone, that's much more potent. 5 milligrams prednisolone is equivalent to 5 to 6 to 20 to 25 milligrams of hydrocortisone. You need to give also 20 to 25 milligrams of DHEA with the prednisolone. Do you know if Thymosin alpha-1 is available in Canada? I don't know if Thymosin alpha-1 is available in Canada. It's available in this. Well, it was available in the States. You need to check it's if it's available, it will have registered as Sadaxin, Z-A-D-A-X-I-N, for hepatitis. Generally, if it's possible that it's in China. It is in Europe, it's only registered in Italy, so we get it from Italy. I have a perimenopausal patient who I treat with low dose of estriol gel and oral progesterone according to your books, but she developed slight continuous smearing bleedings. This, if she's perimenopausal, how to adopt the dosage? Well, basically, you generally have the solution in my hormone handbook. If she has continuous bleeding, she has too much estrogens, and not enough progesterone. So if it's in the first half of the cycle, I would decrease the estrogel. If it's in the second half, you need to increase progesterone. But I think that she needs to take a lower estrogen, and the reason that she bleeds might be due to the fact that she's not applying the estrogel carefully on the arm. So it should be on the whole surface of the arm, in and out arm and the shoulder for one pump, and then the second pump of this estrogel on the other arm, upper and also the shoulder, and go 10 times over and over. Then if it's applied on a too small surface, like just a part of the ankle or the wrist, then it comes very quickly in the blood and disappears very quickly. And there are ups and downs of the level of estradiol. When there are ups and downs of the level of estradiol, you get, when there's a down, a bleeding. So she probably has to apply also better the estradiol. So for promote health and to treat the less fortunate patients around the world, you should train more doctors around the world with the least course fees in order that all participating doctors will train other doctors. And so in order that most unfortunate population in the world benefit of you, to kindly consider my 2 cents, suggest thank you very much. I'm very interested in learning the benefit knowledge for you, looking forward to going to the society. In some emerging markets, the local association who's working with us has received also a special prize because they are an emerging market country. And so there are adapted fees for it. So I think you can always try to locally advise or to get on our email, contact our email to see what can be done. Will you update a list of physicians? I'm going to finish the point, but I'm trying to giving the last questions. Will you update a list of physicians trained in your school to find them easily? And as a non-physician, we can work with them. Yes, we have on the Hertoghe Medical School a whole list of doctors who have accomplished some training programs. So that's already a list of doctors that are more knowledgeable. What is the role of SHBG in tumor cancer? Where to balance the SHBG and what treatment you give for a patient with a low or high SHBG? It's only my hormone habit, what you do a low and high, because there are many different situations. I'm not familiar with HBG in tumor cancer, cannot answer you that question, but you need to have an optimal SHBG, which is around the 20 to 30 nanomoles per liter, I think, in men, and about 65 in women, or they are thyroid or sex hormone problems. Are there other reasons to lower DHT other than to prevent hair loss during testosterone treatment? I don't think so. Excessive body hair growth, then is a reason maybe to lower DHT. Do you know if Damazal Isabel Canada already had the questions? And will you please address testosterone testicular cancer? That will basically address this, but basically testosterone can be given after testicular cancer. But there will be a lot of details in one model will be shown. Okay, I have to end now. I'll just end with one question. Will you please send the overviews via email so we can have the information on different, you will have very interesting information with abstracts on each video session that you can attain at the email office@hertoghe.eu, okay? So that's for all the questions for the moment. How many hours of study time per week is needed? 2 hours to assist the training program. And then if you do the exam, you might need some more time, but 2 hours per week is maximum. Okay, thank you for all your questions. I thank you for your attention. You've been a great public, and I hope to see you soon in the other webinars. Bye-bye.